starting our introductions and by introducing yourself?
Yes. My name is Donna LaChapelle, and I'm one of the elders and residents here at NACC, and I'm just so grateful to be a part of this community. So thank you for having me.
Thank you. Thank you, Miigwech. Dr. Myra, would you introduce yourself, please?
Bonjour, I'm Laurel Myra. I'm an enrolled member of the Red Lake Nation, and I'm also the director of Red Lake's new Minnow Bediziwin apartments. And there's also the embassy there, and we're opening a healthcare clinic as well, right down the street from NACC.
Thank you. Thank you, Laurel Miigwech. And then Beth, would you introduce yourself?
Hi, I'm Beth Ryan, and I am the Project ECHO coordinator. And if this is your first time or you're new to attending this ECHO, if you could please, in the chat box, send me your email address and the name of the clinic that you work for or organization you work for, I would appreciate it. Thank you.
Thank you. And I'm Kari Robbie. I'm a physician here at NACC. I am a physician, family practice and addiction medicine, and I run the MAT program. And I will go ahead and share my screen, and we'll go right into it. Okay. All right. So this is our agenda for today. We've already had the prayer and land acknowledgement with Donna. Thank you, Donna. And then I'm doing the introductions and agenda. I'll go through the Zoom guidelines. Dr. Myra will do the announcements. We're lucky to have Dr. Wilhite with us today to present her didactic. And then hopefully Dr. Graham will be here to do his case presentation if we have time. And then we will close. So let us know who you are. As Beth said, please introduce yourself in the chat function. And you can also update your name on the screen so we can see who you are. Just right click on your image and you can rename yourself. And then turn your camera on so we can see you. It's always nice, more helpful to have a conversation with people that you can see. And then we ask that you mute your microphone when you're not speaking. We might mute your microphone for you just because sometimes there can be a lot of noise. That's just so for more clarity. You can use the chat or hand raise function if you want to speak or say something. And as always, no protected health information, please. Dr. Myra, would you please do the announcements for us?
Sure. We meet the first and the third Wednesday from noon to 1. And our upcoming sessions that we have scheduled in May are Addressing Racism with Youth of Color by Dr. Savez, and she is a family practice doctor. And then again on the 19th, we'll be discussing our hearing about reclaiming their right to dream. And this is about working with youth. There's a couple other echoes going on that you might be interested in. These are both through Hennepin. The viral hepatitis echo, which is on Tuesdays, the 1st and the 3rd at noon. And then the integrated opiate and addiction care echo, that's every Thursday at 12:15. If you need any other information or schedule, you can go to the hennepinhealthcare.org / echo project-echo. And then you can also email Elizabeth Ryan, who is also on the call today. And her screen says Midwest Tribal Echo if you would like to ask her questions. Case presentation. So we try to do one case presentation each session. And if you are able, we would love to hear from you and have a case presentation from you and your clinical group. This could be a client that you have or have had. It could be a clinical question that you have from a client now. And what you do is just complete the form that is on the website at hennepinhealthcare.org /echo, or you can email it to Michelle McCochran, and her email is listed there. And we just really look forward to learning from each other and would love to hear some of your cases. So for continuing education, we do offer continuing education for physicians through the Hennepin County Medical Center. And you will receive a survey after the presentation or at the end of the session. And if you complete that, you will receive a credit. And if you are an other health care professional, you can submit the PowerPoint and a description to your board, and typically you're able to get credit that way as well. But you do need to complete that survey as well.
Right, thank you, Miigwech. We now have we're going to allow Dr. Wilhite to share her screen and presentation. Thank you again for being here. I'm going to stop sharing.
Right. Here we go. And let me move you guys over into another window. Everyone see my screen okay?
Yes, it looks great. Thank you.
Awesome. So I'm very happy to be here. Thank you for inviting me. My name is Lori Wilhite. I am a pharmacist by training, and I come to you with a lot of experience working within toxicology and poison control. And for about 10 years more recently, I was working in an interventional pain clinic here at Hennepin Healthcare. So, and now I am the medication safety manager here at Hennepin Healthcare. So my focus for a long time has really been opioid stewardship, improving opioid prescribing, getting naloxone into the community and other harm reduction strategies, increasing our capacity for medication for opioid use disorder, and then focusing a lot on safe medication, safe drug disposal as well, getting medications out of people's medicine cabinets. So if any of you have interest in any of those areas, I would be very happy to connect with you. So our focus today is to talk about a bit about gabapentin. When does it help and when does it hurt? And I'm definitely coming from a medication focus here, but you'll see kind of by the end of the presentation, probably the longer my career as a pharmacist, the less I like medication. So gabapentin is one of those many drugs I think that gets overused a bit and does have some risks that aren't always commonly appreciated. My plan today would be to talk about, again, when does gabapentin work and when does it not work? To talk a bit about the risks and benefits of gabapentin and opioid co-prescribing, and then discuss some of the side effects and the misuse of gabapentin as well. This is my best friend's dog, Lucy. She was experiencing evidently some back pain, and I learned that she was on gabapentin. And it made her drowsy, which is kind of like what we experience in people, right? So that's just a little levity there. Gabapentin, Lucy's gabapentin prescription. I think probably everybody here recognizes that gabapentin's a very commonly prescribed drug, and probably for many reasons, the prescribing of it has continued to increase over the past 10 years or so. And if you're familiar with the Minnesota Prescription Drug Monitoring Program, many of you probably have access to that, but that is essentially a board of pharmacy database that all pharmacies report controlled substance and prescribing to, as well as gabapentin. And you can see last year, really by far, that gabapentin was the most commonly prescribed drug that the Board of Pharmacy monitors. And then the second most commonly prescribed drugs would be drugs like Adderall for ADHD, and then opioids are actually coming in more like third, which I think is pretty interesting. So again, just more data showing how commonly gabapentin is prescribed in Minnesota. Oh, Dr. Grand's here. Oh, sorry, I got frozen there for a minute. And this is just some historical data just to show you that pretty consistently gabapentin has been our most commonly prescribed drug on the PMP for the past 3 years. Gabapentin is, when we talk about indications for drugs, that essentially means the manufacturer has studied the drug and gotten FDA to approve it for certain conditions. And gabapentin is used for a lot of things, but it's specifically approved for certain seizure disorders and then post-herpetic neuralgia, in other words, pain from a shingles infection. But it's very widely used for a number of other conditions as well. You know, neuropathic pain, fibromyalgia, restless legs, anxiety, and we'll talk a little bit more about those indications as well. And I'm aware also that gabapentin has been looked at for alcohol use disorder and other indications as well, but those are kind of less my areas of expertise. You know, personally, I think that gabapentin is so commonly prescribed. One of the reasons is, of course, the opioid epidemic that we're living in. We know that, unfortunately, in 2020, we had a rise in Minnesota in opioid deaths again. And I think more than anything, providers are just looking for something to prescribe for chronic musculoskeletal pain, back pain, you know, recognizing that we want to be much more conservative about who we're giving opioids to. Also with, you know, gabapentin specifically, there's been this legacy of actually the company that originally marketed gabapentin or Neurontin was, had their drug reps out promoting it for indications that weren't approved by the FDA, and were actually fined money for that. So again, I think the gabapentin was sort of, you know, it was promoted for chronic pain. There's also another drug related to it called pregabalin or Lyrica, and that one has pain indications as well. And then of course, I think, you know, the chronic pain and the opioid epidemic wouldn't be so difficult to solve if we had great alternatives to opioids for a lot of patients. And certainly there are like interventional therapies and wellness approaches and alternative therapies that are good for chronic pain. But in terms of you know, medication, we are a society where oftentimes patients expect a prescription, or we've been kind of conditioned to think that pills are the answer for pain. And for some folks, Tylenol or acetaminophen doesn't work for them. NSAIDs, the drugs like ibuprofen, you know, naproxen, meloxicam, can be quite effective for various types of chronic pain, but many people, for various reasons, can't take those because of other medical conditions or perhaps drug interactions. You know, providers are held to patient satisfaction metrics where, through my experience at the pain clinic, you know, what I saw quite often was that people would come to an appointment with it for a pain provider, you know, expecting some sort of prescription. And then, you know, we unfortunately availability of things like pain psychology and alternative therapies, interventional therapies, comprehensive pain programs aren't always readily available for everyone. And I think that's a big area of improvement. So, you know, some people I think have taken the approach with gabapentin, you know, why not prescribe it? People want a prescription. It's better than an opioid. Well, kind of the problem with that is it just reinforces the tendency for people to view pain treatment through, you know, through a pharmacologic lens. In other words, you know, I need a pill for my pain, and we all know that none of these medications really address the underlying reasons for people's chronic pain. Adverse effects with gabapentin, you know, it is a medicine that tends to be pretty well tolerated if it's given by itself, but when it's prescribed with other drugs that cause drowsiness, especially causes a lot of, you know, drowsiness, dizziness, central nervous system type effects. And then of course, there are the issues surrounding misuse of gabapentin. If people overtake it or use it in other ways that that aren't prescribed, certainly it can cause some issues. So what I'd like to talk to you a little bit about is that unfortunately or fortunately, if you have a patient with chronic back pain and they say, well, you know, my friend is on gabapentin and it helps for him and it helps him. The data really shows us is that drugs like gabapentin don't work well for low back pain or radicular pain, which would be back pain that originates in the back and kind of shoots down the leg. Gabapentin and Lyrica, neither one of those drugs work very well. Neither does the anticonvulsant topiramate. So again, these drugs have never been shown to be terribly effective for back pain. The drug pregabalin or Lyrica has been studied for sciatica, which again is that back pain that radiates from the back down the leg. In a pretty robust trial that was published in the New England Journal of Medicine, showed that pregabalin or Lyrica was not effective in the short or long term for kind of that shooting back pain that sometimes we prescribe these drugs for. You know, one medication that one struggle, of course, is as a pharmacist, I know it can be kind of a downer and say, oh, these are all the drugs that don't work and give people side effects. But then, right, we're still left with, well, then what are the alternatives kind of? And Duloxetine is actually a medication that I kind of like or prefer over trying gabapentin. It's an SNRI, so it kind of shares a lot of the mechanism of action. You might be familiar with drugs like venlafaxine or Effexor. So the Duloxetine has been shown to be effective for chronic musculoskeletal pain. FM is fibromyalgia, neuropathic pain, and then as well, it can help people with major depression and anxiety. So we know that mental health issues can certainly coexist with chronic pain. And so Duloxetine can be, I guess I'm always a fan of prescribing fewer drugs to treat perhaps more than one condition if that's indicated. So one thing with Duloxetine for most patients is that you are looking at a target dose of at least 60 milligrams a day. So for patients maybe that have had tried it in the past or think it doesn't work for them, if they've only been on 30 milligrams a day, 60 is more the dose that we're looking at. So it might be a benefit to increase the dose before you call it a medicine that's not effective. Moving on to neuropathic pain a little bit. So again, low back pain, gabapentin, pregabalin, not very effective. But for neuropathic pain, certainly this is a medication that does work and is inexpensive and generally covered by insurance plans. So neuropathic pain is certainly a condition that I do support giving gabapentin for. And many of you, I'm sure, treat patients, diabetic patients with peripheral neuropathy and are very familiar with a lot of the symptoms that people report, tingling, numbness, that are generally more severe at night, pain with walking. Sometimes it can be painful to even touch the affected area. And then folks can often develop sleep problems and balance problems from that as well. Just some kind of common assessment tools to help you, kind of figure out, whether you should try gabapentin. And then also something I find with gabapentin is that it gets started, but we don't always follow the patient very well to figure out if it works. So, and it's definitely a medicine that it's a good idea to deprescribe it if you give it a try and it doesn't work. So there's a couple of nice neuropathic pain questionnaires that I included in the presentation here, and I'd be happy to share those with you if you don't have a copy of the slides. This is a questionnaire called the DN4 questionnaire. And just to review some expert guidelines about treating neuropathic pain, the American Diabetes Association supports the use of pregabalin, which is Lyrica or Duloxetine as first-line agents. Again, Duloxetine might be a good choice for someone that perhaps has a coexisting anxiety or depressive disorder that isn't already being treated with another antidepressant medication. And then kind of a backup is gabapentin, although, a lot of people's insurance do require that you try gabapentin first before pregabalin because it's less expensive. You're probably all familiar with tricyclic antidepressants like amitriptyline for diabetic neuropathy, and those drugs are very effective and definitely worth a try if Lyrica, gabapentin, or duloxetine don't work. They can have the benefits of helping with sleep as well, but they do, they're very toxic drugs in overdose. They cause anticholinergic effects. They tend to be quite sedating, so I don't consider those first line. And then, opioids generally are really kind of a last line therapy for peripheral neuropathy, and one that should really only be used as kind of a last resort. Similarly, like other guidelines from other organizations recommend the drugs like duloxetine and gabapentin and tricyclics as first line. These particular guidelines talk a little bit about capsaicin and lidocaine as well. Lidocaine patches aren't well covered by insurance for neuropathic pain, so I usually advise that people go to the dollar store and get, they sell 4% lidocaine patches and the prescription ones are 5%. So it can be nice to go to the dollar store and pick up just like single patches and see if they're beneficial. Capsaicin, kind of that spicy hot pepper chemical that's in hot peppers like jalapeno and so forth. There's a transdermal patch therapy that has to be administered in a doctor's office that's been tried for this. We don't really use it much anymore. You can try like an over-the-counter capsaicin product too. And then again, third line therapies being strong opioids. At our pain clinic in Hennepin, we do have a provider that also does some spinal cord stimulator therapy for refractory neuropathic pain. So that can be an option as well for folks that have really debilitating pain that hasn't been addressed well by lifestyle changes and medication. Other drugs that have been tried, if you've been practicing for a while, you probably recognize that seizure meds are often something that we kind of throw at neuropathic pain if other medications haven't worked. Of all of these kind of seizure meds, I think that are worth a try for neuropathic pain, I would say carbamazepine or Tegretol would be the one with the most evidence behind it. Kind of shifting on to some of the drug interaction concerns that that I alluded to in the beginning. I don't recommend prescribing gabapentin with opioids if you can help it. The reason for that is, there can be a number of reasons, but opioids, we know, slow down the gut, right? They cause constipation, just kind of slow down the GI. And there's actually been research to show that because of the way opioids slow down the gut, that the absorption of gabapentin is actually increased. And so you're basically getting more gabapentin in your system along with the opioid. And we know that both of those drugs cause dizziness and drowsiness. One research study actually went as far to show that high doses of gabapentin, like 900 milligrams a day or more with opioids, were associated with a higher risk of death, even when the amount of opioid is controlled for. So if you were, say you started somebody on gabapentin for neuropathic pain and they weren't responding well to it, and you had them up to an effective dose, which is like 900 milligrams a day, if you needed to start opioids as really sort of a last resort, I'd recommend tapering off the gabapentin. For those patients who would benefit from gabapentin, I would say, think about using it safely. Maybe even think about it like a benzodiazepine, where you'd use it very sparingly and only if needed, and not combine it with an opioid. So if you have a patient that's on more than 1,800 milligrams a day, especially if they're elderly or maybe have decreased kidney function, think about whether you could taper them down to a lower dose. If you have a patient on gabapentin and opioids together, think carefully about risk and benefit, and provide them with naloxone. Avoid opioid, benzodiazepine, and other CNS depressants together. And I would include things like muscle relaxers in that group, Baclofen, cyclobenzaprine. And the FDA has required new warnings in the labels of gabapentin and pregabalin about the risk of life-threatening or fatal respiratory depression in people with respiratory risk factors. So something to keep in mind. I would also specifically avoid gabapentin and hydrocodone co-prescribing. Hydrocodone, of course, is what's in Norco and Vicodin and Lortab, due to a special drug interaction because of increase in gabapentin exposure with that. I mentioned or alluded to a little bit about patients with kidney dysfunction, that we need to address gabapentin doses, and give your pharmacist a call if you have questions about that. And then just to end a little bit talking about gabapentin misuse, and I'm sure there's others in the group that have more familiarity with this, but I think it's commonly misused, of course, because it's widely available. It's not a controlled substance in Minnesota. It can have very sedating and euphoric effects in high doses, and it's not commonly detected on urine drug screens either. We know that it augments the effects of opioids. Sometimes people like to mix it with other drugs like quetiapine or Seroquel to get kind of an additive effect. I know some of my pharmacist colleagues in correctional facilities have told me that gabapentin is something that is susceptible to misuse in that population as well. For those of you that work in the addiction medicine field, you probably won't be surprised at this data that it's, very common to have folks using gabapentin, in addition to perhaps buprenorphine or methadone when they're in treatment. Again, probably just to sort of augment the effects of the opioid or for other reasons. And I found it interesting that about 20% of a large sample of urine drug screens in one toxicology laboratory were positive for non-prescribed gabapentin. Back in the day when I worked at the Hennepin Regional Poison Center, calls about gabapentin were super common, and that's probably not gonna surprise anybody here. Most commonly, sedation was the most common reported side effect. And when you combine drugs like alcohol and opioids and benzodiazepines with it, you're at higher risk of intubation and other adverse outcomes. Gabapentin withdrawal is something that does occur, and when people are prescribing it for, say, neuropathic pain, I do recommend a taper. When it is stopped suddenly, people can get a little agitated, confused, sweaty, have some GI symptoms. So probably like almost any CNS active drug, it's probably a good idea to taper it rather than stop it cold turkey. And to just kind of provide a summary here, I'm looking forward to hearing your questions and discussion, but what I'd like to really kind of get across is to only use gabapentin and pregabalin for conditions in which it is effective, and then titrate up to maybe 900 to 1800 milligrams in patients with normal renal function, and then taper it off if there's no benefit at 3 months. I would review the prescription monitoring profile before you prescribe it, just to make sure that your patient is not taking like an opioid or benzodiazepine or getting gabapentin somewhere else first. I'd consider prescribing, again, naloxone. Monitor for early refills and other concerning behaviors. Be mindful of patients at increased risk. And again, use non-medication therapy as really a first line for back pain and chronic musculoskeletal pain. But medication alternatives to gabapentin, again, would be drugs like duloxetine, acetaminophen, and oral and topical non-steroidal anti-inflammatory drugs. For osteoarthritis and small joints, I'm a big fan of topical diclofenac, which is over the counter now, AKA Voltaren gel. All right, that is my last slide. Does anyone have any questions or experience that they'd like to share?
What was the name of the topical ointment you mentioned, or cream, last there?
Yeah, the brand name of it is Voltaren with a V, Voltaren. And diclofenac is the generic name, Diclofenac. And that's widely available at, CVS, Target, Walmart. Really nice for like osteoarthritis in the hands and wrists and kind of some of those small joints. Also a lot safer than taking oral NSAIDs as well. There's pretty minimal absorption of it.
Thank you.
Mm-hmm.
Yeah, thank you so much for that presentation. At NACC, I feel like we saw the rise of gabapentin, we were in the front leading edge of that in terms of like what people around us were seeing. And at this time, we're seeing it less prescribed for pain than we are for things like anxiety. Most of my patients who are taking buprenorphine are really very, very attached to their gabapentin. And we're very aware that we're very, very aware that there are diversion issues and misuse issues, and from a harm reduction standpoint, we're really struggling to navigate those issues, and especially it seems especially for our patients to be something that they feel helps them a lot. And we've wondered about things like, is there a connection with post-traumatic stress disorder, or is there something else going on that makes this a drug that our patients feel works really well for them. Again, in knowing it as well, that there are things like diversion going on and other forms, other ways that it's being misused.
Well, one nice thing about buprenorphine is it has a lower risk of respiratory depression than other opioids. So probably a little safer combination, the gabapentin and buprenorphine versus gabapentin and other opioids.
Yeah. We are not prescribing the other ones, but yeah.
Yeah.
And we do try and keep on. Our absolute limit is 600 3 times a day, and then most of our patients are 300 3 times a day.
That's great.
Can you speak at all to the urine toxicology with gabapentin? Because I've looked a lot for data on how to interpret it, and a lot of our patients are maxed out on the levels, and it doesn't seem to have any correlation with the dose that they're taking. Do you have any information about that?
So you're talking about like quantitative levels in the urine? Interesting. I would say gabapentin's like a lot of other drugs that we use where there's significant tolerance associated with it. So, right, probably like a quantitative level in the urine is probably not associated with toxicity in a tolerant person. Also, with the way that I've been told by the toxicologists in our laboratory is that quantitative urine levels probably, just because of all the variables with urinary excretion, it's right, they aren't terribly usable clinically. Is that what you found as well?
Oh, we're finding them because we don't know how to interpret them. Yes, the levels are completely useless. The fact that it's there or not is sometimes helpful, but the levels aren't helpful.
Right.
Yeah.
Right.
I was hoping that maybe you had some information. I was hoping we could find a way to interpret them, but because
I don't. Yeah, I think that it's in general in urine toxicology that I know with alcohol metabolites there's some correlation between alcohol use and alcohol metabolite like quantitative levels, but with gabapentin, I'll look and see in some of my toxicology references, but no. And I would guess the same would be true of serum levels too, right? It's probably a lot of variability, and with urinary excretion too, it's like, do we really know? There's just so many variables there.
Thank you.
There's also a question in the chat from Christine Matson. She's wondering if there is any evidence that being on gabapentin helped decrease risk for relapse with illicit drugs.
I don't know the answer to that question, but some of the addiction docs in the group here might.
Oh, we can't hear you, Dr. Graham. You're not on mute, but we can't hear you.
Sorry, I was on double mute. So I think, and this may be the root of your question, Chris, This is from a question from Chris Matson up in Ashland. So there's a really interesting study recently on benzodiazepines with buprenorphine, which showed that benzos combined with buprenorphine, interestingly, both increased the likelihood of retention on buprenorphine. And at the same time, if somebody was lost to follow up on buprenorphine and they're returning to illicit opioid use, then the likelihood of overdose, either non-fatal or fatal overdose, was higher. So it's kind of an interesting mixed bag of it both increased the likelihood that you're going to stay in treatment, and at the same time, if that didn't work out well for you and you were lost fault, then you're more likely to have a bad outcome. So I think some people have taken that. I've heard people interpret that study on benzodiazepines in a similar light to gabapentin, where there's both an increased risk of overdose. There's about a 1.4 times increased odds of overdose when you're on gabapentin with other opioids, and generalize that. So that may be where you're coming from, Chris, but I've never seen a study explicitly say gabapentin has any impact on retention and care.
Yeah.
And actually, I see there's a chat that just came in from Jeremiah Atkinson. I'm gonna spin off on that, Jeremiah. That's a great question. And I'm actually curious. So Jeremiah's question to you, Lori, was, can you give recommendations for transition from gabapentin to duloxetine? A spin off on this that I was curious about is, I've never seen any data on actually adherence to gabapentin. So like I know like 3 times a day medications in general only have like a 15% likelihood they're going to take it 3 times a day. Twice a day it's up towards like 30 to 40%. Once a day it's much higher. Gabapentin I feel like is one of those exceptions because people feel it, where it's one of those few medications where it's 3 times a day, but you feel it each time you take it. So can you comment on a likelihood of adherence to either regimen? And then I think Jeremiah's question is great, where how would you, or do you know of any evidence kind of talking about that transition?
Yeah, I don't know any evidence. The way I would approach it, I suppose, would be if a patient is, number one, I'd probably look at the risk factors for if you're combining the duloxetine and gabapentin together. Are they old or frail or elderly, where you'd be concerned about increased side effects of like maybe drowsiness, dizziness by combining the two for too long. If I were concerned about that, I'd probably more aggressively taper the gabapentin down like within a week or something. But if it were someone that, where you didn't have like real acute concerns about the drug interaction, I would just recognize the fact that it's going to take the duloxetine, probably at least 2 to 4 weeks before you really get a therapeutic effect from it. And in that case, you could keep the gabapentin on and maybe taper it by 25% a week or something like that, just so maybe you're giving some time for the duloxetine to kick in. And I suppose that probably, right, that assumes that the patient was getting benefit from the gabapentin. With like gabapentin and Lyrica, they have such a similar mechanism of action that I usually would recommend just kind of stopping one and starting the other one.
Thank you so much.
And is the gabapentin titration, is that like a 10% per week, or is it
Yep. To titrate up?
Down.
Oh, to titrate down. Gabapentin has such a, right, it has a really short half-life. Like if you were gonna just take someone off gabapentin because it wasn't effective or it wasn't working, again, I would probably say if they were having adverse effects from it, that you could titrate down very quickly, like within a week.
Yeah, I was thinking more for the withdrawal.
Oh, sure. Yeah. 10% a week is always that's what we do with opioids, right? And so the problem with the gabapentin is like the dosage strengths that it comes in, or it's kind of tricky to taper it like that with those little increments sort of, without it getting messy with a lot of different strengths of capsules and things. So I would just take that into consideration when you're doing the taper.
Yeah. Now, I have to say, one of the things I find challenging about prescribing gabapentin, which is, I think, is one of the sort of the red flags about it too, is just the shifting, like, why are you taking it, you know? And so are you, you know, a lot of patients will start taking it for pain, and then they're finding it's helping their anxiety, and it's, you know, kind of just basically taking the edge off of life.
Right.
Which is, you know, which is, like I said, like kind of a red flag.
Yeah, absolutely. Yeah, sometimes it can be a difficult sell to taper it off. But on the other hand, if you're not concerned about safety and the patient's finding it helpful, it's and you're not combining it with other substances that put them at higher risk, it's probably the lesser of a number of other evils.
Yeah. Well, yeah. So like, that's our guideline at our clinic. So I think that's very helpful to hear you say that. It eases my anxiety about it a little bit.
Takes the edge off.
Yeah, a little bit. Anybody else have any questions or comments?
There's a question from Valerie Custis. Valerie, would you mind just sharing your question?
Sorry, I'm up north and I don't know how good the connection is here, but I've had a lot of people tell me they've experienced catastrophic weight gain after starting on gabapentin. Is that common?
I haven't found that to be common. It can cause some peripheral edema sometimes, but in terms of catastrophic weight gain, I guess I haven't seen that. What have others' experiences been?
I've never heard anybody complain of that. And I'm not saying I haven't checked for it, but I've never heard anybody say I've gained a lot of weight on gabapentin. Dr. Grant?
It's interesting, on the manufacturer's label, it actually says that weight gain, independent of peripheral edema, has listed as an adverse effect in up to 14% of people, 10 to 14%. So I would also agree that it's not commonly cited. I've only had 1 or 2 patients came in specifically describing weight gain that they attributed to it. That said, I don't get regular weights in my addiction clinic, so I can't say exactly. So I don't know. I've never heard of people describe catastrophic, but I definitely have had a couple of people, although infrequently, describe some mild degrees of weight gain.
I have had, I mean, I definitely, in sobriety, a lot of my patients gain weight. I mean, that is absolutely true. And so, and we always attribute it to the sobriety. So it might be helpful to know that, actually, to suggest that might be one of the factors causing weight gain. But so yes, I've seen weight gain in people in sobriety who are also taking gabapentin.
Thank you. That's what I was looking for, something to bring up as a potential deterrent for more and more and more meds.
Aren't we all? We have 5 minutes left. Any last questions? I don't think, again, we're not going to have time for our case presentation. Dr. Graham is going to do with us, I think.
One of the things, just out of curiosity, just to pull, I've just kind of drawn a line in the sand that I personally don't prescribe more than 600 TID of gabapentin. And that line I drew mostly because of a study done by the last name of Maldonado for moderate alcohol withdrawal management. And because most other studies for like neuropathic pain went to much higher doses than the older studies, but I've kind of drawn a line of like 600 because there's really no great study for like anxiety or these other things. I'm just kind of curious on a community level where people have drawn that line in the sand.
So my line is 3. So I have a soft line of 300 milligrams, And then if people come to me that are already on gabapentin from other prescribers and they telling me it's helpful, then my line is 600. If they come to me on 900 TID, I say I'm not comfortable with that. I'm not and I drop them down to 600. And that's just, and then it's also helpful that our pharmacy, the Muskogee pharmacy, I think, their line in the sand, I think, is 900 TID. So they won't prescribe above that. That helps. But yeah, I don't have a single patient that's higher than 600 TID. Anybody else?
I also just want to articulate, because I think for people on this call, it may be more common to think about gabapentin in the setting for alcohol use disorder as well. And I just want to acknowledge that when I have used gabapentin as an intervention for like a home alcohol withdrawal management or other types of things, it's actually really helpful to know what people are on chronically. And sometimes I'll actually tell people, if you're actively drinking, don't take gabapentin. Not because necessarily it's going to be a major adverse effect, but because you lose the ability to use more gabapentin when you really need it. And so I've had people taper down on their own from gabapentin, even though it may help their like alcohol-related or alcohol-induced neuropathy, because they were trying to like save it, so to speak, for when they're trying to cut down in the future. And I think that's actually a really helpful way to message it as well for people that do struggle with alcohol, is that it can be really helpful for withdrawal management without having to go to higher levels of care, potentially, depending on their background. But if it seems like a good idea and potentially safe to do at home, preserving that so they're not taking it concurrently, because otherwise their GABA essentially tolerates at the higher level, and then you'd have to add even more on, and that's where people get really uncomfortable. So I'm usually trying to help people to stay low.
Are you seeing anybody on gabapentin long term for like just sort of like alcohol in recovery for alcohol?
I found it for a limited number of people helpful. Again, it goes back to that scope creep. Like you started, I think there's not a ton of data going beyond like 12 weeks for alcohol withdrawal management. I think it's a better study was one done by Ray Anton, where you get naltrexone plus gabapentin. And in that study, he stopped the gabapentin at 8 weeks. Although there was an increase in return to use after the gabapentin was stopped. So that's where people kind of beg the question, in studies by Barbara Mason and others, say, should we be on gabapentin longer term? Whether it be for like subacute withdrawal or anxiety or whatever that may be. People have described kind of reductions in alcohol cravings for gabapentin, but that's where it gets really vague. Is like, is it 300 TID? Like, what's the right thing for that? So I usually don't go there because I haven't found particularly good luck in reducing return to use, although people may describe a reduction in cravings and or anxiety. Sometimes I think people conflate the two. So yeah, the data is mixed in the literature. I find it a little hard to interpret, frankly.
I also try not to prescribe gabapentin right when I'm inducing them on the buprenorphine, because I kind of want to know, what's what. It's 1 o'clock. Thank you all for joining us today. It was a wonderful discussion. Thank you so much, Dr. Wilhite, for bringing the slides with you. And yeah, if we could have everybody have a good week, and I'll keep the core team here just to debrief. Thank you.
Thank you. Gabapentin.
There we go. remove, and then they're all removing themselves, and I try not to remove you guys. That was a good discussion. Then it's for me, I don't know how you felt, Dr. Grant. I'm sure you know all this stuff already, but for me, it just functioned to just reinforce that nobody knows, and I'm not doing anything wrong yet.
I think that's one of the best parts about ECHO is it just kind of like reinforces what are people doing, because I think to a certain degree, everybody, there's always that gray, right?
Yeah, totally. So we've got those two echoes coming up, and then I think that's Dr. Myra, do you want to join us in some of the content discussions moving forward?
Sure. Yeah. Those ones are on Wednesday, right?
Yeah. Are you and Dr.
I can
Gran,
do the Wednesdays.
Are you able to do that next Wednesday, Dr. Gran?
Yeah.
Yeah, because I think we did a big brainstorming session next time, and I'm also sort of feeling like I'm sort of feeling like we might be ready to reach internally a little bit more and like pull in some of our internal experts to talk, and to like, I'm thinking about like Simone, and who else was I thinking of? There's somebody else internally that I was like, we really should have them do an echo. And then also some of the people who do some of the harm reduction work around us that we work so closely with, like the Jacks and Rosemary Pfister and even like Healthcare for the Homeless. I don't know if they're doing any, but I think that, and I'm also recognizing in myself that I tend to give the same speech over and over. And so maybe really asking people, what do they want to talk about? And I know that that's different from creating a curriculum. What do you think about that, Dr. Grain? Because I know that, when we created the curriculum before, we went and we said, this is what we want to cover. And then we went and found people to cover those topics. It's different from asking people, what do you want to cover, and seeing if it fits with us.
Rosemary has,
Go ahead.
oh, I'm sorry. Rosemary has presented on like treating housing unstable patients.
I reached out to Rosemary, and she said, what did she say? She said something like, I don't know if I can contribute, which I was like, I sort of feel like you can. What did she say? She said, I don't know if I'm doing anything or knowing anything special to share, which I'm like, huh. Yeah, so I'll talk to her again, because I feel like she does have things to share. So that's kind of where I'm at. And then Dr. Myra, I know that the talks that you've given on equity have been very helpful as well. So
yeah, just to reflect on that, the question you posed before, I would say that in general, I don't have any issue with it. The question that I have is just from the audience perspective of, do they know what they're signing on for? So for what reason do they chime in? I mean, some people may just be a routine thing that they do on Wednesdays or regular Wednesdays, but some people may be looking for topics. So if they don't know what's coming, then it's harder to predict.
Well, I'm suggesting having a curriculum, but not to have it be more like, no, I'm not suggesting we don't know what's going to happen from week to week. I'm suggesting we have a calendar of talks, but not to be telling people what we want them to talk about, but more reaching out to people who we know have expertise in the areas that impact our clients, and asking, what do would you like to give a talk on? What do you think would be relevant? And then we decide if we want to bring that in or not.
Sure. I think that's totally a fair approach, in terms of just the grassroots, like what do people hear and feel. I think that to balance that, it's your experience with Rosemary, oftentimes we go in with at least a vague sense of agenda. Just because oftentimes people say, well, I don't know what you want me to talk about. And it's hard to get people to find a focus or
that makes sense.
They personally identify as the expertise. So sometimes just having a prompt for where generally you're thinking about that it's going can help people stimulate their own idea of what could they feel like they can share.
That makes sense. So some one-on-one conversations with people about what we think would be helpful, and then sort of like balancing that with what they feel they can do.
Usually that's just more of I find when I try to do that, it just takes a lot more time, because it's a lot more negotiation with the individual oftentimes multiple conversations back and forth. But I think that's a very valid way to come up with a curriculum.
Mm-hmm. Yeah.
And then I would just challenge or ask who outside of NACC is doing that work, whether it be an outstate or other places, to make sure that you get a full perspective on what would be considered valid topics.
Okay. We've got these people, these consultants here right now, and they're calling me.
All right. Well, thank you.
Yeah,
We'll talk later.
Thank you so
Cool.
much.
Bye.
Congrats, Noelle, on your new gig.
Thank you. See you
Mhm.
later.
We're glad to still be connected.
Okay.
Bye.